Assalamu alaikum. Welcome back to the session. We will start back with the clinical day. The first scenario, Mrs. Julia Smith, 50 years old, female with vision problems. Please sit with her, examine and address her concerns. Dr. Salma and Dr. Huda, if you're ready, we can start after sharing the timer.
Can I start?
Just a moment. Yes, here you go.
Hello, my name is Dr. Abdurrahman, the doctor in the clinic today. Can I confirm that you are Mrs. Julia and your age is 50?
Yes, doctor.
Nice to meet you, Mrs. Julia. So I need to ask you some questions and I need to examine you as well as answering all your concerns. Is this okay with you?
Yes, okay.
Okay, Mrs. Julia. So, Mrs. Julia, what brought you here in the clinic?
Yes, I have problem in my eye and how to see, and I came to know the reason for it, doctor.
So I'm so sorry for what happened to you, and I will try my best to help you. So can you exactly tell me what you mean by problem in your eye? Is it like blurry vision or pain in the eye or
Yes,
seeing double?
Yes, I have just lost the vision in my eye completely, doctor, for a few seconds. And after that, everything was normal, and I came to know the reason for it.
So, Mrs. Julia, is this happening for one eye or both eyes?
It's in both eyes, doctor.
In both eyes, okay. And when did exactly this happen?
It started 2 days ago. Actually, it started when one eye 2 days ago, and previously I have the same episodes in the other eye. It's lasted for a few seconds, and as I mentioned, I completely lost my vision. Yes.
Okay, so Mrs. Julia, you said that 2 days ago this happened to one eye. Which one? Is this the right eye or the left eye?
And my right eye.
Your right eye. Then after that, another episode happened to your left eye. When that was?
Yes, it was about 2 weeks previously. Also, I have the same thing, lost vision in other eye, and after that, everything for a few seconds, and it was normal after that.
Okay, so Mrs. Julia, so that lasts only for a few seconds, and then everything back to normal. Before that happened, did you see any change in your vision, like see flashes or any change in the vision?
No, doctor.
Any headache at all?
Yeah, I have headache. Yes.
Is it associated with the episode or even without the episode?
No, even without the episode.
And since when this headache started?
It just all the time I have this headache all over my face.
For how long?
It's not specific. It could be for all over the day. Sometimes just in a certain time. So it's not specific. And
so did you say that this headache started months ago or weeks ago or days ago?
Maybe for months I have this headache. Maybe.
Is it worsening, this headache, or improving, or the same?
It's the same.
The same. Okay. In which part of your head?
It's just all over my head, doctor.
Okay. And how can you rate this headache from in a scale from 1 to 10, 10 being max?
No, it's just a 3, doctor.
Okay. So this headache is just 3. Okay.
Yes.
So is it increasing by something specific like coughing, sneezing, bending forward?
No, doctor.
Okay. So is it associated with any feeling sick or throwing up?
No.
Okay. So it is relieved by itself, or you take something to relieve it, or have rest?
When I have rest and it's come back normal. Yes.
Okay, okay. So back to this visual loss. Is this the first time happening to you 2 weeks ago? Like before that, what about your health? Did you face any similar condition or any other problem?
No, doctor.
Do you have any past history of high blood pressure, high blood sugar, or high cholesterol?
I have a high blood sugar, doctor, and I'm on insulin injection.
And how is it? What about your last hemoglobin A1C?
Yes, it
Last
was
blood sugar reading? Mhm.
9. Mm.
9. Okay. And what about your insulin? How much do you take, and what the type of insulin that you are taking?
I take it just 10 units maybe in the morning and 15 minutes at the evening. Yeah.
10 minutes from what? You
10
mean
units.
mixed card or short acting?
I
Sorry?
just don't remember exactly the name, doctor. Just an insulin.
Mm-hmm. So are you taking only one type of insulin?
Yes, doctor.
Okay. And when you are taking this insulin, do you take it in a different places in your body, or where exactly?
Yes, I change sometimes in my tummy, sometimes in
Mhm.
my arm. Yes, I change.
Mhm. Do you
Mm.
notice any change in your the skin of your body, or the muscles of your arms, or something? Any change, like redness, like pain, like anything, swelling?
No, doctor.
Okay, okay. So how do you store this insulin exactly? Where do you put it?
And the fridge, doctor. I store it
In,
well.
okay,
Mm.
okay. Are you adherent to this insulin? Are you taking your doses every day?
Yes, doctor.
Any recent change for the dose of the insulin
No,
recently?
no,
Okay, okay. Uh, so this is about this insulin. Do you take any other medication rather than insulin?
no, doctor.
Do you have any other problem rather than diabetes?
No,
Okay. Mrs. Julia, can you tell me if you feel any uh, weakness at all in your body at any time before or during this time?
no, doctor.
Okay. Do you have any shakiness of your hands or something?
No, doctor.
Any dizziness when you change your position from sitting to standing?
No,
Any abnormal sensation in your peripheries like hands and feet?
no, doctor.
Okay. Any yellow discoloration?
No, doctor.
Anyone commented that you are paler than before?
No.
Any tiredness at all?
No, doctor.
Okay. Any change in your weight?
No, doctor.
Okay. Any change in your appetite?
No, doctor.
Any lumps or bumps in your body?
No,
Any skin change anywhere in your body, like
no,
in the skin color? Or okay. Do you have any a feeling of confusion, or any apart from this headache, any confusion?
no,
Sorry,
no,
the mic, please. So, okay. Do you feel like any problem in your memory, problem in remembering things?
no.
Okay. Any pacing or racing of your heart?
Sometimes, yes.
Sometimes. So,
Mm.
since when this started?
I noticed it for months.
For a month.
Right.
So,
Yes.
is this episodic, like coming intermittently or continuous all over the day?
Yes, I sometimes feel that there.
Your voice, Dr.
Yes,
Huda.
yes.
Sorry.
Sometimes I'm rising in my heartbeat. Yes, doctor, and I notice it
Okay.
for months now. Yes.
Okay. So, do you feel any strong awareness of your heartbeat along with this?
Yes.
Okay. Any cough at all?
No cough, doctor.
Any shortness of breath?
No difficulty. No.
No shortness of breath.
Yes.
Any cough of blood?
No.
Okay. So anyone commented that you are snoring at night or something?
No, doctor.
Any morning headache especially, or all over the day, you said, just for double check?
No, doctor, it's all over the
All
day.
over the day. Okay, okay. So Mrs. Julia, can you tell me if you smoke?
No, doctor.
No. Okay, if you drink alcohol?
No.
Okay. I'm sorry, I have to ask you some private questions. Do you have any problem or any change in your period?
No, doctor.
Okay. Are you with one partner?
Yes, I'm married, doctor.
Married. Okay. Do you have kids?
Yes, 2 children.
Okay. So I need to back to the question. Sorry, just I need to ask you a couple of questions. Do you have any problem in your water work amount or frequency or color?
No. No.
Okay. Okay. Any change in your bowel habits, like loose motion or hard stool?
No, doctor.
Okay. Any tummy pain?
No.
Okay. Do you have a job? What is your job?
I'm a teacher, doctor.
Teacher. And how much these symptoms impacted your job?
Yes, it's affecting me a lot, doctor, with this vision problem.
Okay, I'm so sorry for that. So we can involve our occupation health to help you in this manner, to see what they can give you in this manner. Okay, are you okay with that? Okay.
Yes.
So Mrs. Julia, do you drive?
Yes.
And I just recommend you to withhold driving for now and inform DVLA, because the vision problem now, it is recurrent. I mean, 2 times happened to you. So I need to, to make sure that you are more safe. Okay?
Okay.
Okay. So Mrs. Julia, can I examine you?
Yes, doctor.
I need the vital signs.
Yes, the blood pressure is 120/80. The pulse rate is 100. Temperature is normal.
Temperature is normal. What about the blood pressure sitting and standing?
Normal, doctor, no change.
So I need to examine the pulse. Is it regular and synchronous?
Irregular.
Irregular. The pulse is irregular. Okay.
Mm.
So can I examine the eyes? I need to examine the eyes for visual acuity now.
Okay.
Mhm.
Okay, negative visual acuity now. Mm.
Normal, you mean?
Yes.
Okay.
No fine.
Okay. So I need to examine the heart, cardiovascular. First, start with the JVB. Is it normal?
Yes, normal.
Okay. Then the heart for any murmur.
No murmur.
Okay. Then the chest for basal crepitation.
No basal crepitation.
Okay. I need to do the pronator drift.
Negative.
Negative. I need to do the lower limb swelling.
2 minutes
lower limb
left.
edema.
Negative.
Okay. Okay. So, Mrs. Julia, what is your concern?
Yeah, I want to know the reason for this vision problem, doctor.
Mrs. Julia, your concern is valid, and I appreciate your concern. Actually, you have problem, transient problem happening to your vision. I mean by that, something may be related to your uncontrol of your diabetes, because your hemoglobin A1C was very high. It could be the possibility in my mind is a transient ischemic attack. That's a medical term for a medical condition where your blood, there is a clot, small clot in the blood channels that's supplying your eyes, causing you the symptoms that you have. And because it is happening twice, that means we need to pay attention to your blood sugar and to any other risk that's causing this. We need to admit you for now and do more blood tests and images to confirm our diagnosis, to rule out others. And then we will say a group of doctors will take care of you, including the brain doctor and the sugar doctor, and then we will sit with you to give you the proper diagnosis and plan of management. So do you have any other concern?
No, thank you, doctor.
So, Ms. Julie, I need to remind you also that I need you to stop driving for now because of this vision problem until we will know the exact cause and to inform the DVLA. And if you have any, I will give you some leaflets and brochures about your problem. And if you need any other concern, you can just ask me. I think finished.
Okay, yeah, time's up. Let's go to the examiner questions. Dr. Huda, please start.
Okay, so doctor, can you present your finding in this case?
So this lady is 50 years old. She's having 2 episodes of loss of vision for seconds, and then and she's having headache for 4 months. She's having diabetes, which is uncontrolled. Her hemoglobin A1C is 9, and she's having also a palpitation and tachycardia. And on examination, I could not appreciate any abnormalities on the examination in the heart, or she's not on failure. There is no neurological finding. I could not appreciate any neurological findings. So my differential diagnosis would be, the top of the diagnosis would be transient ischemic attack due to uncontrolled diabetes.
Okay, what else other than transient ischemic attack?
Actually, multiple sclerosis can give us the same picture of recurrent vision loss, transient vision loss, but her age is 50, so but it still could be a possibility. And
other than multiple sclerosis?
I did not ask about this. Giant cell arthritis, but in 2 different occasions. Yeah,
Yes.
we should exclude giant cell arthritis, actually.
Yeah. Okay, so what investigation you will send for this patient?
What investigation? You said?
Yes,
so,
what investigation in this case? Yes.
Okay, so apart from basic investigations, CBC, renal function test, liver function test, inflammatory markers, and we will do for this patient hemoglobin A1C again, and we will do remind me.
Okay, so she have an AF. She will send for that.
Yeah, atrial fibrillation. I'm sorry, I forget this. So we need to do ECG and echo and chest X-ray. We need to do especially echo to find out if she's having any like mitral valve problem or something.
Okay. So in case she presents with this acute loss of vision, you will admit this patient, and the first step would be given her which medication, and after that,
in case she came with acute,
what medication?
Aspirin. I think we will start with aspirin. Yes.
Okay, so the indication for admission in this case of TIA, why you admit her?
Because she's having now currently atrial fibrillation. She's not aware of, and but she's not on failure, and there was no indication that she's now on any like a stroke or something. But because of this atrial fibrillation, and also to control her diabetes properly.
Okay, thank you, doctor. Finish my question.
Okay, still 1.5 minutes. I will ask you, Dr. Salma. I just wrote the question. When to admit this patient? There is criteria of admission for TIA. Do you know it?
Actually, when Dr. Huda asked me, I realized that maybe she's not for admission, but because
she's not for admission, but she's for
transient ischemic attack. Yeah.
Okay, tell me, she's for not for admission, but she's for
not for admission.
And she is for?
Regular follow-up and the outpatient clinic for investigation and
Good. So you will refer her to TIA clinic. What
yeah,
kind of referral?
TIA clinic.
Yeah, what kind of referral? What do you call it? Is it routine? Is it regular? Is it
No, no,
urgent?
it's not
Is it
not routine. No, no, urgent referral.
so urgent? For how long? Or within how many hours should be seen by the neurology?
Okay, I believe maybe 24 or to for 24 hours or 48
Yeah,
hours.
exactly. Yeah, no, it's
24,
24 hours.
24 hours.
Yeah. Okay. What
Okay.
image or what test you will do for this patient as a neurology?
Neurology will do for her
Yes.
احنا عندنا two things, multiple sclerosis and giant cell arteritis and transient ischemic attack. So I will start with the
Okay, let's focus on TIA now because the topic of
TIA.
it, yeah, the question will be
Yeah,
around one topic, not all. How
okay.
you investigate for TIA?
Okay, I
What
will.
image? What? Yes, please go ahead.
Okay, اسمها I will do brain CT called T4 ولا I can't remember the name.
Diffusion test. Yes.
Diffusion.
So what's good?
Diffusion.
What's this is CT? You said CT or MRI?
Uh, I said CT, but I think MRI.
You said the CT with the name of that MRI.
Yeah,
T2
CT
T2
diffusion.
diffusion. Yeah.
Yeah.
No, it's not CT,
Okay.
MRI. MRI, okay?
Okay.
Okay. Why not CT? And when to do CT?
I
Two
can't remember.
questions. Okay.
Mm.
If the symptoms persistent, you will do what?
Mm. If the symptoms what?
Persistent.
Persistent?
Yeah, patient present with the vision problem more than 24 hours. What you will do, CT or
Mm.
MRI? And what we call this?
If the symptoms persistent,
Yes,
then this
persist
is
more
not
than
TI.
24 hours.
Yeah, so
Perfect.
that
It
is
will
not
be
TIA. That is as the stroke. Stroke
perfect.
aneurysms
Yes,
for God's sake.
it would be
Yeah,
a stroke. And what
stroke. Yeah.
the test of choice in the stroke?
Mm.
Is it MRI?
Uh, CT in this case.
Exactly. Why you want to do
Yeah.
CT initially?
I think they are م- لا لا كده ملخبطة.
Anyone can
نسيت.
write? Anyone can help here? Why you want to do CT
Exclude
initially?
hemorrhage.
Perfect.
To exclude hemorrhage.
So
Yeah.
yes, so you will do CT if you have suspicious of stroke, if symptoms persist more than 24 hours. First thing to
Mm.
rule out hemorrhage. Why you want to rule out hemorrhage? So
To
the
give
question will
aspirin
come
or
like
not?
this. Yeah,
Yes.
exactly. Yeah. So the question or the discussion will be like this. Every answer will have question on this answer. So the CT to rule hemorrhage, to rule out hemorrhage, and to start or to load here with aspirin because if there is hemorrhage, of course you will not give aspirin, right?
Mm.
And
Yeah.
if you have TIA and the symptoms less than 24 hours, this is the time to do MRI. What other image you want to do apart from MRI?
Again for the TIA,
Yes,
or
now you are
because the patient is having atrial fibrillation and we suspect that she's
perfect.
having impulse,
Okay.
so MRA in this
No,
case,
no, no.
and cardiac also echo.
Yes, perfect. Okay.
Mm.
What
Mm.
else? Image. I'm talking about image. You have to know this image.
Mm.
Yes,
Yeah,
someone
the
got
blood.
it. Yes,
Mm,
carotid Doppler.
mm,
And if you have AF, you did ECG and you didn't find any, what you will do? Any abnormality, what you will do?
Again, the question, please. If I have
You have AFib
atrial
and the
and I
ECG,
didn't
12
find,
lead ECG, yeah.
yeah,
No
carotid
AF.
Doppler
What?
came negative, then I will think of valvular and do echo.
Okay, I'm asking about AF per se. You have
Mm,
AFib, but the
mm.
ECG doesn't show AFib. What you will offer?
Yeah, so
Yes. Holter.
you mean
Yeah, no AFib
I have
in the
AF?
ECG. Yes, you don't have ECG showing AFib. What I should do
Mm,
for the
mm.
patient, because I suspect AFib,
Halter to
right?
catch it, yes.
Yes.
Yeah,
Okay.
halter to catch it.
The last question. Last question.
Mm,
If you have,
mm. Good questions.
yes, this is the discussion usually.
Mm,
It will be like this. Okay, if you
okay.
have AFib and yeah, confirmed AFib and she's female, there is, apart from diabetes, what other test you want to do, particularly in the females?
Let's conduct a pregnancy test
Tests, specific
because
tests.
she's coagulable state.
Uh, uh, okay, thrombophilia, what else?
Thrombophilia.
And something can lead to AFib. So you have to test and screen for that, for this.
Mm,
Yes,
thyroid.
it's the yes, exactly. Usually,
Mm,
these are the common question for TIE. You have to screen for the cause of thrombus
mm,
or embolic.
mm, mm,
AFib,
mm, mm.
yes, of course, one of them valvular heart disease, thyroid, hyperthyroidism, thyrotoxicosis, lipid profile you didn't mention at all, and she mentioned to you by name, I have high cholesterol. So you have to include it in the tests, cholesterol and
She,
lipid profile. I will, sorry,
mm.
she said,
She
okay,
didn't, but you are right. Lipid profile is very
no, no,
important.
she said cholesterol. I think she said cholesterol, right, Dr.
Really?
Huda?
No, I didn't mention
She's,
cholesterol.
Mm. But still, it is very
you
important,
ask
yes.
about
Lipid
cholesterol.
profile.
Yeah, maybe
Mm.
Dr. Salma ask her if you have cholesterol or high cholesterol. Okay,
Yes,
maybe
that's
I
right.
yeah, but perfect to mention it in the history, and please
Mm.
don't forget it in the screening. Okay,
Yes.
it's one of the okay. Sorry, Dr. Huda, you can comment now. Then I will comment.
Okay, so
Thank
this
you, Dr. Basim. That is very precious. Thank you.
Most welcome. Okay. Go ahead, Doctor.
okay, this is a 50 years old female presented with a transient loss of vision on a background of arterial fibrillation. So the analysis of the problem of vision would be, what do you mean exactly? She will tell you that it's like a curtain from above down. So it's an amaurosis fugax. And then you will go to the explore more why she have this transient loss of vision with the could be a vascular cause. So explore more about, first do CNS analysis, any weakness, any numbness, dizziness, any fits, abnormal movement. Um, do full CNS analysis. She will tell you no other than this loss of vision. Other thing to exclude in the history, she had a history of diabetes on insulin. So maybe exclude the signs or symptoms of hypoglycemia, could be precipitated transient loss of vision, any hand shake, hand sweating. Did you check the blood sugar when you have this episode? Other thing you excluded in the history, which is the migraine. Did you have any flashing of lights, any specific characteristic of headache of migraine? Seizure could be also any abnormal movement or fits. And lastly, could be due to temporal arteritis. Would be the character of the headache would be directed due to temporal arteritis. Um, throughout the history, the CNS analysis, and then the systemic review. Regarding she is a female, it's very important to ask about the contraceptive pill. You ask about is she married, the period, but you didn't ask about the contraceptive pill. The smoking, you ask the alcohol, driving, okay. Regarding the examination, first you start by the eye. You just only did the visual acuity, but I think it's important to do visual field and also offer a fundoscopy. And then maybe examine the cranial nerve, simply maybe the H-shape movement to exclude the sixth cranial nerve, the third and the fourth, and maybe just facial nerve for the cranial nerve. You did examine the upper limb for tone power, maybe just reflexes. And important in this case to check the pulse for atrial fibrillation, and then auscultate for valvular area, and also auscultate the carotid for any brewy, very important in this case. This all my note regarding the investigation. They يعني, you discuss it. But this is the differential would be TIA, hypoglycemia, could be migraine, could be seizure, and could be lastly temporal arteritis. That's
Okay,
all.
Thank
perfect,
you,
Dr.
Dr.
Hoda.
Huda.
Yeah, very nice
Very good,
case.
thank you.
Yes. Thank you, Dr. Hoda, for the comment and for the preparation. It's nice case and very common topic. In this age, you have to think, as Dr. Hoda said,
Mm.
TIA, especially with the comorbidity, blood sugar, hypertension, thyroid, thrombophilia. Okay, Dr. Salma, if I said to you, yes, my father had a clot
Mm.
before, what
Family,
you
family
should ask
history.
about? Yeah. So what you should
Uh,
ask about?
the thrombophilia screen should, maybe she's inherited any type, and what else in the family?
Yeah. So what are the possible cause of thrombophilia, familial condition?
Factor 5 and protein S and C, I think, deficiency.
And what the common?
The common among them, factor 5, villedin. Von Wilbran will give bleeding, but
Yes, it's okay.
mm,
So you can say thrombophilia disease or blood disease.
yeah,
What
blood
other
disease
cause?
run in the family.
Mm-hmm.
And in this age, diabetes causing problem like this, but clot.
Yeah.
Nothing
Dr.
come in
Huda
my
already
mind.
mentioned OCBs, right? Okay, this is as external
So
factors.
you mean
What about the
female?
genetic?
Uh,
Yeah, female
mm.
and no, genetic. Okay, let's talk about genetic or familiar condition with thrombophilia.
You said father, but I
Paroxysmal.
should ask about a recurrent miscarriage like this, maybe also
Perfect. This is the most
phospholipid.
common.
Yeah,
You have to rule out,
phospholipid.
but
Mm.
it's not familiar condition. Let's be
Mm.
in the same concept. It's
Mhm.
running in family, but it's not genetic, right? But it's very common to have
Yeah.
autoimmune and SLE and antiphospholipid is the most
Mm.
common thrombophilic condition in the exam. Deal?
Okay, deal.
Right. Okay, the next, as you said, the genetic, including paroxysmal nocturnal hemoglobinuria,
Mhm.
or as you said, factor V, leading, or antithrombin, or all of them, but they are not common as, for example, paroxysmal nocturnal in PACEs, I mean. And also you
Paroxysmal
can add
nocturnal.
to them hemoglobinuria and sickle disease, sickle
Sickle
cell, which
disease.
is anemia. Yeah.
Mm.
Plus inflammatory bowel disease as thromboembolic disease. And as you said, also the miscarriage related to antiphospholipid,
That was good.
OCPs. So remember
Mm.
all these condition whenever you have thromboembolic disease.
Disease.
Okay.
Okay.
Okay, let's go back to comment about the history taking. I think, and you
Mm.
think also, the history was not organized, right? Agree for
Yes,
that, or
the time, although the time also, I noticed that 11 minutes I took for the history. So,
okay, leave the time now, but we have to be organized.
mm,
Okay, you have to do it in organized way. Really, they are focusing in this point in the exam. By the way, I got 28 out of 28 in both long clinical scenarios. 28 out of
MashaAllah.
28.
MashaAllah.
I did the same
MashaAllah.
what I did in the video I share. You remember the video how
Mm-hmm.
to take history and organized? I made it in the
Right.
same way. And no
Mm-hmm.
comment. I think because it's a full mark, so I think no comment. Even if they will comment, I will tell you in the feedback. But and again, I did it in the same way. Onset course duration. Let's do it as a revision. Onset course
Mm-hmm.
duration, the relevant system
Mm-hmm.
analysis. Then, if you have alarming or constitutional, ask about the constitutional symptoms.
Mm-hmm.
Then, the past medical history, just to know if you have some background in the patient history, and the system review. Every system, one or two maximum questions, and don't miss any system. I hear some mentors saying don't ask about all system. No, every system, one question is enough. Even it will be negative, but this is the system review. This is the main idea of system review. You have to ask every system, or you have to analyze every system. So ask every system by question, one question or two question maximum. Then the social
Okay.
history about family or travel, or if you have HIV. At the end of session, I will tell you my cases, the long cases. Then
Mm-hmm.
the last thing: do you smoke? Do you drink alcohol? Do you drive? And what's your job? Believe me, if
I
you do
asked
this
these
in
questions, Dr. Basim,
yeah yeah
earlier because of the scenario, because
of the
I was
vision.
afraid to forget them. Yes. That's why I brought the smoking, alcohol, and driving early, not to forget them, because I
Mhm.
know if I forget them, it will be fatal mistake. Then I
It's
continued
okay.
after that my history.
Believe me, if you wrote your scheme in the paper, you'll not miss anything. Write it in the same way. I
Okay.
wrote it in my paper, by the way. I wrote this scheme in my paper, and I followed them one by one till the examination. Then I did the
Mm-hmm.
examination. I will tell you later also about the examination.
Mm-hmm.
And alhamdulillah, I got, as I said, 28 in both scenario, which is
MashaAllah.
it is very
Which
difficult.
center, Dr. Basim? Which
Alexandria,
center?
Alexandria, Alexandria.
MashaAllah. Mm.
I'm saying that because this is the most preferable way to do the system review and analysis. And according to everyone, if he has his approach, follow it. But I'm saying what I followed in the exam, and they judge me in this performance. Let's go back
Mm-hmm.
to your history. As I said, your history was
Mm-hmm.
not organized. You ask for system review, then you go back to the some social, then you ask about vision. You didn't analyze the vision well about the night vision, the color vision, double vision, pain, discharge, redness, all these
I asked
questions.
about double vision,
Okay,
but when I realized that this is mostly TIA, I dropped the others and go to the risk factors.
still you have to ask.
That's what
The
happens here.
Yeah, the question for multiple sclerosis. What is the specific question for multiple sclerosis? And you have to ask. This is female, although
Mm-hmm.
she is not young, but still she is female, and you have to ask this. What the question? If you suspect multiple sclerosis, what the specific question you have to ask about?
And about multiple sclerosis, I asked her only if she has any weakness before, and I know that the symptoms of multiple sclerosis, I think, triggered or increased by uh,
Perfect.
uh,
This is the question.
hot bath. أيوة.
Yes,
Sorry.
exactly. This is the question you have to ask. Weakness, it could happen with the stroke, right? Weakness, it could
Uh,
happen with TIA.
It was in my mind, yes, but I didn't ask because
Yeah.
after diabetes, I
Yes.
concentrated on the MTIA. Yeah.
Yeah, we are learning. We are learning, Dr. Salma. So
Mhm.
the
Yeah.
vision, the topic of vision is very nice. I like this topic. And believe me, if
Yes.
you learn how to do it, analysis and system review and relevant system
Mm.
CNS, you will get the case. Definitely you will
Mm.
not get the case. The previous history also is very important to ask. Is there any previous attack or no?
Yeah, I asked
Because
her.
if you have previous attack, what you will suspect? Yes, doctor, I have this before. It
She
happened with
has
me six
actually
months,
she has actually previous attack 2 weeks ago, and I
2 weeks.
asked her if she has another attack before that at all. I
Okay,
asked this question.
perfect.
Yeah.
If you have,
Mm.
or if she had previous past history of the same attack of double vision or vision affection, what you suspect by years, for example, or months. The-
mm.
I have 6 months of
Yeah,
double vision,
yeah, like
pain or
first
on
multiple
vision. What?
sclerosis, but she's not.
Yes, but that's yeah. This is
Yeah.
what I want you to
Mm,
know. Yes, exactly.
mm,
So the
mm,
previous history is very important in such
mm,
cases. TIA it will come as acute. Yes, it might come as and the question for when to admit TIA patient, which is called
mm.
crescendo type. Crescendo type. So the symptoms are
In 15
increasing.
days. Yeah,
Yeah.
actually, this lady, if this Crescento, yes, I remember it. If
Yeah.
Crescento, this lady for admission because she has
Yes.
2 weeks previous left eye attack, and then 2 days ago again attack. So
Yeah.
two
This
attacks in two
exactly.
weeks.
Yeah.
Yeah,
So this is indication for this is a
for
question.
admission. Yeah, yeah.
Perfect. Exactly. Yes.
Mm.
Okay. I think yeah, this is my comment, but please don't forget to write your differential in the paper. In this age, the most important TIA, stroke.
TIA, yes. Yeah,
Yeah, migraine.
and
I think it would be earlier. You
yeah,
can add here
temporal arteritis and
perfect,
yeah.
perfect temporal arteritis or giant cell arteritis. And what the question for
Mhm.
giant cell arteritis? The
If she's
question.
if she's having any pain in her face when she's
Perfect.
touching the yeah her
Okay.
face, or in a mastication, or she's eating, or she's
Perfect.
like this, yeah.
Perfect. And it will be
Mm.
associated with
What
condition
do you
female also in the 50s. There is common condition associated with
fibromyalgia
Polymyalgia.
and pain.
no, no, not fibromyalgia. Yes, PMR,
Uh-huh.
polymyalgia rheumatica, PMR.
Polymyalgia rheumatica, yeah. I
Yeah,
mixed between them, yes.
yeah,
Can
yeah.
you
You have
just revise for me the polymyalgia rheumatica quickly? What are
yeah,
the questions?
yeah. Stiffness in the joints
Muscle.
or stiffness in the shoulder.
Mm-mm.
This is
Stiffness.
yeah,
Mm.
stiffness in the shoulder.
Mm-mm.
This is the polymyalgia rheumatica. Okay, and
Okay.
also giant cell arteritis, as you said, any pain while eating or feeling
Mm.
some difficulty while eating,
Mm.
or any tender
Yeah.
or painful areas in your head, which is the scalp.
Mm.
I mean, okay,
Mm.
okay, perfect. That's enough for the discussion, for the revision, also for the comment.
Thank
Uh,
you. Thank you
yeah,
so
most
much.
welcome, Dr. Salma. Please, can you write your scenario to Dr. Huda?
Yeah, I send it in the
Yeah, I
chat.
think. Yeah, okay. Also, the question I asked during the examiner question, I think it was clear. Anyone has doubt? Fundoscopy, yes, I remember now the examination steps. You have vision problem, and you
I
just
wrote it. I wrote it in my paper.
yes,
Once vision problem under it fundoscopy, but
not
again I
only
forget
fundus.
it.
Make it in this abbreviation, Dr. Salma.
Mm,
Okay, write
yeah.
down
Right.
afro,
Okay.
afro,
Afro.
AFRO. Yeah,
Mm-hmm.
AFRO. A for acuity,
Mm-hmm.
F for
Acuity.
field, acuity field,
Field.
R
Mm-hmm.
reflexes.
Reflexes.
Yeah, and the last is O ophthalmoscopy and H
Ophthalmoscopy.
afro H which is H shape. H shape. You have to do H shape for
It's
double vision.
shape. It's
Yeah.
shape.
If you didn't
Okay.
do this examination in any eye complaint, you will miss the case.
Mm,
Not as the
okay.
diagnosis. You will miss the marks for examination. This is the most
Mm-mm.
important examination to do. And you have to pick some finding from this examination steps. Either
Okay.
fundoscopy, retinitis pigmentosa, papilledema, or H-shaped double vision for
Mm,
multiple sclerosis, or
mm, mm,
the field for acromegaly and homonymous hominopia.
mm,
And the acuity, of course, if you have patient with retinopathy, either diabetic or hypertensive.
mm.
So you have to do in this manner. Afro H. Afro H.
Okay.
Don't forget it
Okay.
again, okay?
Inshallah. Inshallah. Thank you
Yes,
so
I
much.
will.
Thank you.
Excuse me,
Yes.
if you have time, could I comment?
Yeah, Dr. Dalia. How?
Yeah, of course.
Hello. Okay.
Hello.
So, yeah, great performance. You reached
Thank you.
diagnosis, but I have some comments to polish your performance. So
Thank you.
for the differential diagnosis, from outside, if you just have vision loss, if you put a scheme, it is acute, or it is something is acute, or something is subacute, or something chronic. Okay, so if it's acute or hyperacute, you have a differential. Okay, so that's why I'm coming to that. MS shouldn't be mentioned in this differential. Shouldn't be mentioned. That will affect the differential diagnosis and clinical judgment. So if I have patient from outside, I put a scheme, sudden or acute, and then subacute. Subacute, I mean 2 weeks or so. Okay, or days, matter of days to few weeks, and then chronic, and then more than 2 weeks and ongoing, and something like that. So usually, and during the exam, it's something related to either subacute or acute. Okay, so for acute, I have you ask the question: is it one eye or two eyes? Because when you have acute, you will put on your mind which pathway I should go from the start. Okay, if it's one eye, that means there is problem in the eye. Okay, or if it's by both eyes, it's the problem in the brain. So how could I find that useful for me? If it's one eye and it's a matter of seconds, that means either most probably this is vascular or electrolyte disturbance. So this it should be on the top of my differential. Electrolyte disturbance, mainly the sugar. With this background, it's mainly hypoglycemia and sometimes hyperglycemia. You could cause some blurring of vision as well. But hypoglycemia is more common. Okay, so then for the vascular, it's called the vessels could supply the retina or the optic nerve. It could be affected. So it's some kind of vessels have been affected. This is if one eye and acute. Okay, if both eyes and acute, something like that, it could be TIA, as in this question. Okay, and or a migraine or a seizure. Okay, so something is coming in like a seconds and then disappeared. Okay, if it's CIA, it's most probably is occipital one. So I need to ask about symptoms of the occipit. That's like vertigo, imbalance, and so on. Okay, I could ask about dizziness. You've asked, I know, dizziness and see double. With any loss of vision, ask, do you see double? Okay, and so, and you will ask, as you've asked about the headache, because you put the migraine. That's what's really nice. You ask about the migraine, and but you took a long time to ask about migraine. So it's usually you have a headaches in your life. He said yes or no. Okay, recurrent headaches in your life. Don't ask long because you will waste your time. So you do you have previous headaches before? Are you recurrent headaches? So I said no. Just recently I have this headache. Okay, and actually this is the scheme from outside. And try to let the patient from the start open question. Open question has his own marks. You said that what's brought you to the hospital, and the surrogate said, yes, I have problem with my vision. You could ask, could you clarify more for me? What do you mean by change of your vision? And let the patient don't guide, it's like a blurring of vision or like, don't put him in, just describe the type of problem. Let him talk about, this is an open question, it's very important. Okay, yes, could you tell me more about that, or clarify more, what do you mean by problem in your vision? And then he'll tell you. Okay, and keep, if you're from start, ask the patient, do you have any past medical history of note before I go further? And is this a first time? Is one eye, two eyes? And you go down quickly because you have a scheme in your mind. Okay, so in this patient, because you have a background of diabetes, you will ask about complication of diabetes, acute and just vascular or electrolyte. And you need to ask when its palpitation appeared in that. So TIA is still okay in the top of differential, and you could be hypoglycemia symptoms with palpitation, sweating, dizziness, and all things of hypoglycemia. So just ask the question in a row, so the examiner will understand that you put hypoglycemia in one of your differential. Okay, and then migraine and the other differential. So as you done, and you've mentioned that you will contact the occupational health therapist, occupational department, that it will be, you could deduct mark from you for that because this affect the clinical judgment. So it's when acute problem happen, please don't contact the occupational health department, please. And this is, if is still unwell, you could give sick leave, only sick leave, unless it's something chronic or with disabilities or something need to change the shift or something. This really need to the occupational therapist to help with that. Okay. And and for the examination, you need to put because vascular, you need to put giant cell arteritis. Ask about any joint pain, any skin changes, or as you mentioned. And when examining patient with visual loss and his age is 50, please examine the temple of the patient. And look, is it palpable with headache and with vision changes? Examine the temple of the patient. And
for tenderness, you mean?
Yeah, it's palpable or not, because
palpable.
When you examine for giant cell arteritis, if it's palpable, temporal artery or not. Okay, this is important.
Yani in the exam, I need to just put my hand on the temple of the patient,
Temple,
you mean?
yeah,
Okay.
and feel it.
Okay.
With any patient with headache, you put the giant cell arteritis, please do that. And with vision loss. Okay. And you need to do if a patient with irregular pulse or something, please do a thyroid examination. If you any tremor or check the neck for any lump and do some. Okay. So because important thing, when I have patient with diabetes, I will do endocrine and I will do something if it's related to the vascular complication of the endocrine system or association. The thyroid is important here. Okay. And it could be hypoglycemia related to Addison. You've asked about the dizziness with sitting, with standing. I love that. Okay. And you ask about the migraine as differential of that, and seizure, and all of that. So it's okay. Just try to shorten your sentence as much as you could. Okay. And the part that I didn't like, when you are explaining the concern for the patient, please, if you have few possibilities, because the patient, okay, the communication for the patient, don't let the patient confuse. So if you give a lots of differentiators to the patient, that is wouldn't give the good impression and will confuse the patient. I could hit you with many questions. Okay. So yes, I have few possibility. We need to work on that. Okay. So we'll keep you for a while. We need to do some blood test. Okay. And then we'll update you about the result, and we'll let you the proper plan of management. So you need to check the blood sugar for the patient. Okay. First of all, the most important thing, the first step, if the consultant asks you what the first step on the examination or the bedside examination would like to do, you will say blood sugar. Okay. This is the most important differential here. Okay. And the second important is TIA, and you need, as Dr. Qasim said, urgent referral to the
urgent referral, yeah, to the TIA.
Okay. For the TIA clinic, but we need to check for blood sugar. Okay.
Okay.
Okay. And that's thyroid, ECG, and all the baseline investigation. Okay. And that's it. Okay. Thank you. Sorry for
Dalia.
أيوة.
Hypoglycemia should be on both eye or when on clear, clear.
Yeah, electrolytes usually both eyes. usually, but sometimes because it's usually both eyes because it's something systemic. If it's
One eye
it's
only vascular.
related to the eye. It's vessels of the eye, the retina, the optic nerve, and so on. And please, for multiple sclerosis, the loss of vision, it will be 2 weeks, around 2 weeks, and then it will gone in its own, and usually associated with pain.
No, not seconds. Yeah.
Not second at all.
I
Okay,
understand.
so don't mention optic neuritis in this condition. Okay.
Okay.
Thank you.
Thank you, Dr.
Thank
Daria.
you.
Thank you for your comment. Anyone has question before going to the next slide? Dr. Huda, your scenario here in the chat box. Mrs. Julia, 39 years with short of breath for 6 weeks. Anyone has question before moving to the next scenario?
I think دكتور باسم في فرق بين التي اي في اميلوز في غاز right التي اي
Yes.
could be there is مثلا weakness, a change of sensation, mouse deviation,
Yeah,
or
neurological
speech problem.
deficit.
Yes,
Yeah, neurological
amyloid,
deficit. Yes.
yes, amyloid for غاز just confined to the eye area.
Yeah.
And
Both
TIA
eyes even. It
confined to
might
the
happen.
eye only.
Yeah, and it might be two eyes, and it will recover back.
Yes, only eyes. It's not in the brain.
Yes. Amaurosis means yeah, for the eye only. Exactly. Okay. Any other questions before moving? Dr. Huda, ready? Dr. Hello, Dr. Huda? You are mute if you are talking.
Yes.
Sorry, I missed.
Yes.
Yeah, you ready?
Yes.
Okay, I will start timer now. Yes, please. Here you go.
Hello, my name is Dr. Huda, one of the doctors in the clinic today. Can I confirm that you are Miss Julia?
Yes.
Julia, we
I
are
am.
here to discuss some issue related to your health condition. Is that okay with you?
Yes, doctor.
Yes, I have letter from your GP stating that you have difficulty in breathing. Can you tell me more about that?
Yes, I have this difficulty in breathing for about 6 weeks now, and it is worsening day by day.
Okay. And before this 6 week, everything was normal?
Before this 6 weeks, yes, everything was normal.
Okay, and you say to me that it's increasing throughout this 6 week. Did you notice anything increase it?
Yeah, any effort that I am doing increase it. That was in the beginning of the 6 weeks. Now, for 2 weeks, I have it even when I am resting. Even resting is not benefit.
Okay. And did you do anything just to relieve this difficulty in breathing throughout the 6 week?
No, this is my first time to seek medical attention.
Okay. And okay, so can you tell me more about this difficulty in breathing? It's mainly when you say that first it started when you're doing activity, right?
Yes.
Okay, and now even at rest.
Now even at rest, yes.
Okay, so when you have this difficulty in breathing, is it start suddenly?
It started not suddenly, yes.
Okay, so do you have any other association with this difficulty in breathing, such as a cough?
Yes, I have cough.
Okay, since when? And you can tell me more about it?
This cough only started 2 weeks ago, and it is dry.
It's a dry cough. Okay, and everything was normal, didn't complain of any cough, just recently in the previous 2 weeks, right?
Yeah, yes.
Oh, and it's a dry. Okay.
Yes.
Any episodes of coughing up blood?
No.
Okay. So do you notice that this difficulty in breathing sometimes when you're lying flat on the bed or leaning forward?
Yeah, in the past 2 weeks, I noticed that when I am lying flat, I have this difficulty in breathing.
Okay. And did you wake up in the middle of night sometimes just gasping for air?
Yes, in these last 2 weeks.
Okay. Did you notice any swelling in your leg?
Yes, I noticed that. You are right, doctor.
Okay. And since when you noticed this swelling in your leg?
Yes, again in the last week, yes.
Okay. And did you see it in both leg, right? Lower leg?
Yes, in both,
Okay.
yeah.
Did you notice when you press on it, leave a mark?
Yes,
Okay. So do you have any medical condition in the past I should be aware of, like high blood
Mm.
sugar, high blood sugar?
no, at all, no, at all. I'm completely healthy.
Okay. Do you have any heart racing?
I have some heart racing, yes.
Okay. Is it since when you noticed it heart racing?
Yes, in the last 2 weeks also.
Okay. And did you notice this heart racing regular or
I didn't pay attention.
okay? And did anyone mention that you are looking paler than usual?
No,
Any bleeding from any other sides in your body?
no,
Any chest pain?
no,
Okay. Okay, so you mentioned that you don't have any high blood pressure, any high blood sugar, any high cholesterol,
no,
any surgery in the past?
no,
Okay, do you have any allergy to any medication or any allergy to other substance?
no,
Okay, so do you have any episodes of coughing up blood?
no,
Okay, okay, so do you have any joint pain, skin rash, or
no,
okay, any stiffness,
no,
any rash anywhere in your body?
no,
Okay, so I will back to this difficulty in breathing again and ask you, do you have any contact with someone with TB previously?
no,
Do you have any runny nose,
no,
rising in your body temperature,
no,
any lumps or bumps anywhere in your body,
no.
any weight changes?
Yeah, I think I lost some weight in the last few months.
Okay, can you remember just how much and over how month?
Yeah, like 3-4 kilos in the last 4 months.
Okay, and did you try to lose this weight or not?
No, no,
What about your appetite?
it's okay.
Okay, so with this difficulty in breathing and weight changes, do you have any sometimes noisy chest?
No,
Okay, no noisy chest. Okay, so okay, do you have any like use any medication in the past or recently?
no,
Okay, do you have any surgery in the past?
no,
Do you have any family condition or disease run in your family?
no, no.
Right. Okay. So, okay, with this difficulty in breathing, I will ask you more about your period now, if you don't mind, Miss Julia. Are you married?
Yes, please. Yes,
Are you married? Okay. Do you have children?
yes.
Okay. The last one, can you mention the age of the last?
5 months.
Okay. Are you lactating now?
Yes,
Mm-hmm. Okay, so okay, so do you use any previously contraceptive pills or problem with your period previously?
never.
Never. Right. So, Miss Julia, do you have any weather preference?
No,
No. Okay. Any lumps in front of your neck?
no,
Any change in shape of your eyes?
no,
Okay. So, any changing in your bowel habits?
no,
Tummy pains, tummy fullness?
no,
Right. Okay. So, do you have any changes in your water work?
no,
Okay. Sometimes you're noticing sometimes a frothy urine.
no, I didn't notice.
Oh, okay. Any puffiness around your eyes,
No,
right? Okay, so do you have any history of clots
Never.
in your any family history of clots?
No.
Any disease run in your family?
No.
Right. Okay. So okay. What's your job?
I'm a housewife.
Okay, and it's affecting you recently with your job?
With my
And your
life and routine, too much, because I am having shortness of breath whenever I am trying to do my houseworks.
Okay, I'm very sorry about that. Okay,
Thank
so
you.
do you smoke?
Occasionally.
How much an hour? How long?
It's just on occasions, not always. For
Okay.
many years.
Right. Okay, I advise you, Miss Julia, to stop smoking, and if you like, we'll refer you to smoking cessation clinic. Okay. And
Yeah.
now, okay, and I will ask you, do you drink alcohol?
Occasion also.
Any binging, drinking sometimes, drinking more than the recommended.
No, I'm just drinking alcohol occasionally, like 2-3 units in the weekend.
Okay. Okay, so I'm sorry to ask you about that, but do you use any illicit drugs or drugs through a needle?
Never, never.
Okay, any herbal medication?
No.
Okay. Right. Okay, so I now will try to examine you, Miss
Yes.
Julia, if you don't mind.
Yes.
I will take a general look to the patient, any cachexia,
No.
or looking for the body mass index of the patient. And
No,
I would like,
90.
Okay, and I would look at her hand, to her chest first, just taking a general look for any scar or any deformities.
Nothing.
And then I will check the apex speed. Is it in place?
It is displaced in the sixth intercostal margin.
And the nature of this apex speed?
But you could not appreciate.
And then I will check for for left ventricular heave and palpable V2, raised JVP, and basal crepitation signs and symptoms of right side heart failure.
It is negative. But there is
And
basic crepitation you will do.
Crepitation. I would do chest expansion in the upper part and the lower part of the chest.
No abnormality.
Okay, so on auscultation, there is bibasal crepitation, right?
Yes, yes.
Okay. Auscultation. Okay, then I will check the hand of the patient, looking for any clubbing.
Sorry, you ask for JVB? JVB
Yes.
is raised.
JVP.
Mm.
Okay, and then I will look to her hand. I will just looking for any clubbing, leukonechia or cholinekia, and then
No, negative.
any signs of infective endocarditis, Osler node or Janeway lesion. And,
negative.
And then I would do, I will ask at this point to check the blood pressure of the patient and the auto saturation.
Okay, the blood pressure is 120 over 70, and the saturation is 98. No problem.
Okay, and then I would do the proximal myopathy.
Negative.
Okay, and go to her eye looking for any pallor or jaundice.
Negative.
Okay, and then I will ask her to open her mouth, raise her tongue for any cyanosis or any ulcers or angular stomatitis.
Negative.
Negative.
And
then I will check the trachea in the neck and the lymph nodes. Any palpable lymph nodes?
No.
Any goiter?
No.
By asking her to take a sip of water and okay.
Negative.
Okay. Lastly, I will go to her leg, checking for any signs of DVT, deviant thrombus, such as redness, swelling, discoloration.
Normal, just
Sorry. Hello?
Yes, we can hear you, Dr. Salma. I think there is problem with Dr. Salma mic.
hello.
You
Yes,
hear
Dr.
me?
Salma.
Yeah,
Yeah.
just lower limb edema, nothing else.
Pitting edema, bilateral.
Yes.
Okay, I will ask you further, Ms. Julia, about your last baby. What about the, is it was a normal delivery or by C-section?
Yeah, it was a normal vaginal delivery like my first one. There was nothing abnormal, but to be honest with you, I felt this shortness of breath in the last month of my pregnancy, and then again 6 weeks ago.
2 minutes left.
Right, okay. And do you have any complication?
Any what?
Any complication went to the
No,
ICU?
no complications at all.
Okay, lastly, okay. Do you have any weakness, numbness, or headache, or abnormal movement?
No.
Okay, so now, Ms. Julia, I will ask you, what's your concern?
Yeah, what is causing me this shortness of breath?
Okay, Ms. Julia, after I'm taking history from you and examining you, most likely you have a certain affection of your heart and how it's pumped, how it's work, leading to the manifestation that you have from difficulty in breathing and this swelling in your leg. It could be due to the recent delivery, which affect your heart. So what we need to do is to admit you, run for you blood tests and imaging, and then we will sit further to discuss the probable plan of management.
So is it treatable, doctor?
We would try to know the exact cause first, assess imaging. Yes, check your heart further with imaging and a blood test, and we will discuss further the plan of management.
Okay, thank you, doctor. Thank you.
Okay, time is up.
Present your case.
Yes, so this is a 39 female presented with 6-week history of difficulty in breathing. And on taking the history, my positive finding was difficulty in breathing, progressive through the 6th week, associated with last week with a dry cough and raising in heartbeats. Throughout the examination, I just could assess by examination there is bivasal crepitation with raised JVP, bilateral pitting edema.
Is she on failure? Is this lady on failure? Heart failure?
Yes.
Yes, okay. So she's having heart failure. What is your differential diagnosis for the heart failure in this lady?
Yes, first differential could be postpartum cardiomyopathy.
Okay.
It could be viral dilated cardiomyopathy.
Okay.
Yes, for this heart failure.
Again, it's viral cardiomyopathy. What? Did you ask about recent flu
He didn't
or
mention
infection?
any runny nose or raising in body temperature. Yeah.
Okay. Okay. What else? Postpartum cardiomyopathy, viral cardiomyopathy, or myocarditis. What else? Could be in a lady recently delivered or lady as general. Anemic cardiomyopathy, right? And anemic heart failure.
Yes.
Yeah. Against that, she is not pale. She did not mention any pallor, any. You did not ask, but you ask about her menstruation in general. She's not having any bleeding disorder indicated by menorrhagia or something. So,
yes.
Yeah, you are right. So what are you going to do for this lady?
Yes, I
investigation?
went for her investigation from general investigation, complete blood count, renal function test, liver function test with an inflammatory markers, thyroid function test, a blood sugar, a blood lipid profile, and thyroid function test, and HbA1c.
How to diagnose postpartum cardiomyopathy?
Yes, sending for ECG, and sending for echo study.
ECG and echo, yes.
ECG and echo study, chest X-ray even.
Chest X-ray, yes.
Yes, Doppler study to her leg.
Yeah, يعني do the investigation for heart failure, including like PMB, all the heart failure to exclude, because it's a diagnosis of exclusion, right?
Right.
Okay. Yeah. How to treat?
Yes. First, treatment. Yes. The treatment would be supply. In this case, in acute setting, it's the ABCD approach. Sitting position, providing with oxygen, and the pharmacological and involvement of heart doctor, and the pharmacological treatment would be diuretics, and anti-failure medication, could be beta blockers or
yeah, treatment of heart failure, the same diuretics, beta blockers, these things. Thank you, Dr. Huda. Very good. We have still time, Dr. Basim.
Yeah, 1 minute. You said beta blocker, Dr. Huda. Will you give beta blocker right now?
In case of she have signs of symptoms of a fluid overload in acute setting, no, beta blocker would not be indicated now.
It will be. And
yes,
it would
until
be.
she is dry, no fluid overload.
So it's contraindicated, right?
Yes, in acute setting.
Yes. So for the chronic only, not in the acute heart failure. Okay. You mentioned some blood test. Which is important to diagnose this patient in failure? Blood test. Specific.
Specifically for the heart failure would be brain natriuretic peptide.
Perfect. Yeah. So you have to mention it as a specific and diagnostic test, right? You mentioned echo. What you want to diagnose with echo?
Yes. To confirm my finding of heart failure by assessing the ventricular function.
Perfect.
Ejection fraction. Yes,
Okay.
and don't assess any valvular lesion.
What types of heart failure you know by the echo?
Yes. There is the dilated cardiomyopathy and the systolic. Yes, dilated cardiomyopathy and the constrictive myopathy and restrictive.
Okay, this is first
by
division.
Echo, by echo, I think systolic
okay.
and systolic.
Yeah. What she mentioned, one of the categories, yes, restrictive, dilated, and restrictive, dilated, and constrictive. Yes, there is another category or another division which is systolic and diastolic. And there is also what's called the most new term and division. What's called?
Nothing come in my mind actually.
Heart failure with and heart failure with. You know, or you don't know them?
No, I don't know.
Okay, so heart failure with preserved ejection fraction and heart failure with reduced ejection fraction, which is HIF. We are saying like this: HIF, PIF, and HIF, RIF. You know them, right? And what are the difference between heart failure with preserved, and heart failure with reduced.
So heart failure with affection of ejection fraction would be dilated cardiomyopathy, right?
It's not dilated. Rather than you can say it's diastolic, reduced systolic, preserve diastolic.
Mhm.
Okay, this is the new division, and accordingly you will give anti-failure medication, either beta blocker or diuretics. So which is more dominant, you will treat. For example, in the diastolic one, you will give the diuretics.
Mhm.
For the systolic one, something related to the pumping action, so you can give beta blocker than the diuretics. This is what one of the most important difference. And
Dr.
this
Basim,
also,
can you explain for me why beta blockers are contraindicated? Because specifically in postpartum cardiomyopathy, that, but
I
maybe
think,
because of associated heart failure, you mean?
yes, if there is heart failure only, it's contraindication. Apart from this, it's indicated. It's reduced the yes the demand, and it reduce the heart rate, they reduce the oxygen demand. But in chronic heart failure, but if you have patient with acute heart failure, it's contraindication. You will exaggerate the failure. Okay.
Because I read here they wrote that beta blockers isorbate, and they are giving for the postpartum cardiomyopathy sometimes bromocriptine.
No, this is
Because
other
they,
cardiomyopathy.
yeah,
Now we are talking about
cardiomyopathy, yeah, heart
failure.
failure.
Yeah, failure is different. Patient in failures, it's contraindicated totally. Absolute contraindication for beta blocker.
I think according
Okay.
to the NOHA grade.
Naiha, yeah, Naiha.
NOHA
Yeah,
grade.
okay.
You can
But
use or
Okay.
cannot.
in acute or in non-acute, this is what I remember. And any cardiologist can, if anyone, Dr. Ayman Shaheen, I think he's cardiologist with us. If he's attending, acute heart failure is contraindication to beta blocker. This is what I remember usually.
Okay.
And
Even
always.
if it acute, and you should know the grade of NOHA. According to the grade, I think severe or not severe like that.
Okay, I think no one cardiology with us. But anyway, you have to know the types and the grades according to NIHA, as you said, Dr. Rashid. So grade 1 and 2 and 3 and 4. Anyone knows them or? So let's say together. Grade 1 with strenuous exercise.
Yeah.
Yeah, so the patient will feel symptoms of heart failure when he does extreme exercise. And grade 2 with, I think, with daily activity. And NEHA
Cardiomyopathy.
3, yeah, even at rest. And I think NEHA 4, while, or maybe 4 is at rest, and 3 while doing the daily activity, and grade 2, I'm not sure. Anyway, we will share it in the group. But grade 4 is someone is not able at all to do any activity. Even he's feeling heart or feeling symptom of heart failure, even with rest. This is what I remember. Anyone
So
updated, he can share with us now. Yes, go ahead. What's your question?
postpartum cardiomyopathy is one type with heart failure. The heart failure would be with reduced ejection fraction.
Yeah, mostly it's was reduced, and it's called peripartum, not postpartum. It's peripartum. The postpartum is thyroiditis. Postpartum, the thyroiditis. Peripartum, cardiomyopathy.
Cardiomyopathy, yes.
And by the way, the peripartum is dilated one. Dilated cardiomyopathy.
Okay.
So it will be systolic because the dilatation make the muscles
Yeah, it
very
is
weak.
systolic, yes.
Yeah.
Yeah.
Okay. Yeah, someone wrote it here, Dr. Hatem. Grade 2 in ordinary activity. Grade in short distance or less activity. Grade 4 at rest. Okay, what about 1?
Is exercise, Dr. Basim.
Yeah, okay, exercise or daily activity.
Exertion.
Yeah, less activity or rest. Okay, thank you, Dr. Dalia. Thank you.
Okay.
For
Just I want to say something
Yeah.
about
Yeah, sure.
as the beta blocker that I'm not updated with the new guidelines. I don't know, but if for the beta blocker contraindication, if the patient is already on beta blocker and she has acute heart failure, okay, that is why it's relative contraindication. So usually they didn't stop it.
But they reduce the
Because-
dose. Yes, they will continue,
Okay.
but I think
Why?
reducing the dose. Yes.
Because when you start the beta blocker for the first time, there is acute effect, negative inotropic effect. So for the first period with beta blocker, you will find that that will affect the heart in the contractility. Okay, so less contractility of the heart, so negative inotropic effect. That's not. It's something we don't want at all. Okay, so if the patient is already on beta blocker for a long time, and we didn't stop it because this is already past this period. And usually it's also contraindicated with systolic heart failure, not with the systolic one. So that I know, but I'm not updated with that. I'm not cardiologist. Sorry.
Okay. We can update in the group. We can ask our
Okay.
cardiologist. And the other thing, yes, they resume or they continue with reducing the dose, not the high dose. This is also what I remember. Anyway, again, we will ask the cardiologists in our group. Any question else, Dr. Salma?
No.
Okay.
Thank you.
Okay.
Thank you.
Your comment, you didn't comment, right? Or you comment already?
Yeah, she did very well, and she find the diagnosis. But and she, I think, explained to the patient in the concern about the heart failure. I think, right? I can't remember. She explained that there is problem in the heart, which is not pumping enough for the demand of her body, and that may be related to her recent delivery. She said like that, right? We need to do further investigation, and then we will come back with the management. So she did very well.
Yeah.
She did not mention the name of the disease. That I remember. She
she
maybe mentioned it for me in the differential only.
Yes, you're right. We should do the same with the examiner, but with focus and non-jargon way to the patient or the surrogate. So you have to tell the patient the name of his condition, not only explaining. He should know the name of the disease. As you are enumerating to the examiner, give the patient the possible diagnosis. He's not asking for differential, but give him the most sensible. What you suspect more, tell him in a name. Don't explain. If you want to explain, tell him the name. Again, you have to give the name with explanation. Carry on, Doctor. Yeah, I just commented on this point. Continue, Dr. Salma, your comment. Sorry for interrupting.
Yeah, it's okay. The history was good also. She asked all the symptoms, although she's asking double questions. A lot of questions, she repeated them twice, but maybe because she was thinking about the possibilities of the differential. And what else? That's only. But she asked about everything.
Yeah. Okay, thank you, Samia. Very nice scenario and common, by the way. It comes especially with female in this age with the previous delivery within the last 6 months. And it can, I think, up to 6 months, I think, 6 months around the delivery.
Yes,
And it
from the
comes
last 3 months of the pregnancy
yes,
up to 5 months after
post.
delivery. It will
Yes.
never come less than 32 weeks of pregnancy. And it came on one center, but I've tried to remember which center, but it came in the bases in the last year, I think.
Even in any center, it can come to other center. It's we have to know all cases nowadays. They are much tough, so we have to have all the possibility and to know all the cases they are bringing. So it's one of the most important case. And the clue in this scenario, the delivery, the age of the last baby or the last delivery timing. If you don't ask this question, you will be lost. It's clear a heart failure patient. She told you about the all symptoms of heart failure. I cannot sleep on one pillow or less than one pillow. I can sleep only while sitting. Leg swelling, dyspnea at night, and gasping for air. All these symptoms is a clue for heart failure. So it's your case clue. You have to ask all this question. But Dr. Huda, I notice you went initially in systematic way, then you went out, then you back to the system review. So what you have to do in this scenario, as you start analysis of the complaint, the relevant system, which is the chest, right? If you want, it's okay to ask about the cardiovascular because it's one of the most related symptom or system to the symptom. So the chest is always related to the cardiovascular, and the cardiovascular is always related to. But whenever you ask, you have to ask all question. You ask about coughing of blood, then you ask it again later on in the system review. Remember what you asked earlier because repeating the question, it's one of the negative comments that you will have if you ask twice. As Dr. Salma said, you ask this question twice and you ask about palpitation later on. Then you ask about the system review, about skin rash and joint pain and back and stiffness. Then you ask again for loss of weight, loss of appetite. I want you to do it in systemic and organized. Whenever you ask about package, continue and finish this package. So if you ask about constitutional, ask all the constitutionals. Here you can ask about loss of weight, any change of appetite, night sweats, night body temperature, lumps or bumps. You can add here if you want. For example, uh, in this patient, you feel pale, or someone asked you or told you you are pale and before. It's one of the alarming and also one of the constitutional. And by the way, it's one of the differential, anemic heart failure, one of the differential. So you can ask this question. Anyone told you your eyes red if you suspect something related to the liver? You can ask also, you have any contact with sick patient with TB? It's one of the alarming and constitutional. You suspect TB if you have this positive. Because you have chest symptoms patient, you have to ask these symptoms together. Okay? Don't jump between here and system review. Finish this package, go to the system review, ask them in the same manner as we know, from the head till the toe. Then the social, family, travel. You ask a good question about the surgical allergy. But again, you ask the surgical history twice. You ask it once with the drug history or with the surgery with allergy. Then you ask it later on. You can ask here also any herbal remedies. Some patient taking herbal can lead to heart failure if you are suspecting. But you have now the case. You have peripartum cardiomyopathy. If you are not finding this in the scenario, you can look for the possible cause of heart failure. For example, you said viral myocarditis. So how you can say this is viral myocarditis without asking if you have any history of infection, any flow,
Yes.
right, Dr. Hoda? So
But in
yes.
this scenario, just because it's shortness of a breath, and
Mhm.
why I was jumping from topic to
Okay.
other, because I
Okay.
confirm it is a heart failure. But what is difficult in this scenario, just to explore more the reason for this heart failure, is very difficult to know.
Yeah.
It's yeah, because I was confused through the history. The only clue in the history here, if I ask if she have a recent delivery or not, because I
Yes.
was just so confused to explore why she have this heart failure. It's very difficult. Unless she will mention initially from the presenting, initially in the history, I have a recent delivery or that. Because it's
Bel-
very difficult to know
no,
the
no.
reason.
Believe me, Dr.
Yeah,
Hoda.
then it will be very easy, Dr. Huda, if I told
Yes,
you.
Yeah.
it will be, you're right, you will be very
Yeah,
easy,
it
but
will
it's
be
Yes.
very
very
But
easy.
difficult.
you're
Yeah,
right. But if you
yeah.
ask this question in system review, you might have some clues. For example, if we ask us from the headache, no blurring of vision, of course, in this scenario, right? And no weather preference, you will come to the heart now. Any heart racing? Definitely, she will tell you yes, there is heart racing. You can ask any chest pain, okay? She might say yes, I have chest pain. Then the next symptom, the GI. Do you have any feeling sick? You have any feeling of heartburn? This is for GERD because it might be also related. Okay, you will skip every system now by asking one question: any change of your bowel habits? Any blood coming from any blood part of your body? Any change of your water work? If there is kidney affection, she will tell you, yes, doctor, my water work being less, or the color is dark, or whatever. So it might be related to the kidney now. If not, you will go to the system, the musculoskeletal system. Any joint pain, if you suspect something related to the joint, for example, rheumatoid arthritis, you will catch the case, right? I have some joint problems, such as joint stiffness, and it would be interstitial lung disease related to rheumatoid, for example. But if not, you will go to the skin, any skin rash. She will say, no, doctor, I don't have. Now, as a female history, you will ask about female history. 3 P's: the pregnancies, the pills, and the period. And you will catch the case in the pregnancy, the last pregnancy 5 months back. Believe me, if they find you in this organized matter, they will give you good mark. But if you ask question from here and question from there, they will minus you.
But doctor, how about the pregnancy? I will get a clue. She will get pregnant. She is not pregnant now. She is
Yeah,
pregnant.
it's not related to the pregnancy itself.
Mhm.
How in any pregnancy, you'll tell you, yes, I had pregnancy before. So
Mm.
how many babies or how many kids you have? I have 3. Ask only about the last kid. How old is he? Or the last delivery. When was the last delivery? So it's related to pregnancy. By the way, this topic, you will know this topic only when you practice this case. Okay?
Yes.
And yeah,
Because in thyroid, yes, we always ask about the lice
Yeah,
because
palpitation and shortness of breath. In presenting symptom palpitation indicating thyroid, or in
and I
shortness of breath
mentioned
indicating heart failure. In both situation, and also in, I think,
weather
pituitary,
preferences.
yeah, these 3 situation for related to pregnancy.
Okay, you mean like pregnancy in paces? Yes, as you said,
Yeah.
yes. Postpartum
Mm-mm.
thyroiditis, peripartum
Yeah.
cardiomyopathy,
The
and
third
the
one, the
Sheehan syndrome.
Sheehan syndrome. Yes.
Yeah, failure to lactate or amenorrhea.
Yeah. Yeah.
Okay, these are the 3 topics related to pregnancy and delivery in paces, by the way. Yes, as Dr. Salma said, you can do this in golden tips. Pick it for yourself. Pregnancy in paces. Pregnancy and delivery. Don't say only pregnancy. Pregnancy and delivery, because it's related to the delivery more than the pregnancy itself. Okay. Multiple sclerosis and systemic lupus. Yeah, they are related, but in different ways. So the SLE will get worse with the pregnancy, but MS will the flare up will be less with the pregnancy. This is another 2 topics, but it's not the main relation to the pregnancy like the other disease. Okay, so it's the disease already there, but it will be flared up if the disease is there, or it might be less if the disease is there. I mean, the SLE, the symptom or the SLE flare up will be more with the pregnancy, and the multiple sclerosis will be the symptoms might be more better with the pregnancy. Okay, so try to do it in systemic way. Just Dr. Huda, follow the system view if you don't reach to the diagnosis, and continue your examination. Do your best as an approach, and hopefully you will reach to the diagnosis. If even you didn't reach, you will put it in the second differential, you will get the good mark. Okay.
Yeah. Dr. Basim, one doctor, Nema, Dr. Abdullah asking common scenarios in heart failure in bases.
Yeah.
Today I practice with you peripartum cardiomyopathy. And I heard also from one mentor earlier today, alcoholic cardiomyopathy. Yeah,
also
the hint,
cocaine.
yeah, it was heart failure clearly. The only hint that when you ask the patient, do you drink alcohol? He will tell you, yes, I drink alcohol. Then you will ask about, she said, cage symptoms, the addiction of alcohol.
Questionnaire, yes.
Yeah, because he will tell you, I am drinking like 15 or 16 units per week. Then يعني more than the limit. Then immediately you ask the symptoms. Then you catch the diagnosis. Before it was coming anemic heart failure. And I don't know if you have something to add, Dr. Basim. Yeah.
According to the type, as you said earlier, ischemic cardiomyopathy, so it will be related to MI and recurrent heart attack. This is ischemic. Dilated, as you said also, it could be HOCM. Sorry, HOCM is not dilated. The dilated will be with diastolic dysfunction and infiltrative, right? Dilated, I think, with infiltrative. Anyway, sorry?
Sorry, the most common one, most common cause of heart failure is hypertensive heart failure.
Yeah.
So don't forget that.
Okay.
Yeah. Heart
And
failure,
also,
hypertensive heart failure. Yes, I was searching for this, Dr. Dalia. Thank you. Yeah, before it was hypertensive, anemic, and now recently appeared this alcoholic and peripartum.
remember also constrictive and restrictive. The constrictive and restrictive. Constrictive like pericarditis and TB, any infection in the pericardium. This is for constrictive. And the restrictive, infiltrative disease. Sarcoidosis, amyloidosis.
Amyloidosis, yes. One case also I witnessed, yeah.
Hemochromatosis, yes, exactly.
Only frothy urine and heart failure. And heart failure. I can't remember else, but this is the case. Only you will find in the systemic review frothy urine and heart failure, symptoms of heart failure. Also this amyloidosis causing heart failure.
Yeah. Yeah, so it's not as a topic, it's related to another disease. You have to know the other clues in the
cause,
case.
Yeah,
the cause and the cause of the same in the symptoms. So as you said, amyloidosis, you will have kidney failure, and the patient will have heart failure associated, but it will not be the main presentation of amyloidosis. It could be association. Okay, so you have to screen about the cause and what other association in the case. As you said, frothy urine. Okay, for example, HOCM, it could be also presented with heart failure or arrhythmia. So you will have family history. For example, you have patient with chest pain, recurrent chest pain on and off. He has heart attack before and he had PCI, and now he's in failure. Why? Because he had ischemic cardiomyopathy, for example. So according to the cause, you can put the diagnosis. Restrictive, as I said, any infiltration, and constrictive, it could be pericarditis, and you have to know the pericarditis nature of the pain nature of pericarditis. Patient will have pain while lying down, and he's preferred to sit or he will be in sitting position. So also you can think about SLE as sinusitis. You can suspect other cause of sinusitis like FMF. So it's a wide range of differential. It's not bare name, but you have to know the type of heart failure. What type of heart failure you have? Is it restrictive? Is it constrictive? Is it dilated? Is it ischemic? Or as I said earlier about heart failure with preserved ejection fraction, or heart failure with reduced ejection fraction. So you don't forget also the valvular heart disease. It might be presented with heart failure. If the patient is having severe mitral regurg, patient will be in failure. Tricuspid regurg will be in failure. Stenosis, pulmonary hypertension, and with the time it will be in failure. So it's not only one single cause you can enumerate. You know, it can have a lot of variety of cases and differential. So according to your presentation, you have to know. In this scenario, as Dr. Salma presented the case, it was related to chest and short of breath with the relation to the delivery. You get the case as peripartum cardiomyopathy. Okay. Any other question or comment you want to add? Dr. Dalia, any comment in this scenario about Dr. Huda?
I didn't listen well to the scenario, I'm sorry, but just to have a overlook for the differential of heart failure. So when we taught before that there is 5 main categories of heart failure. So the first one was the most common is a hypertensive cardiac failure. And the second one is ischemic heart failure. And don't forget the arrhythmia, okay? And then if it's valvular causes, and the valvular causes could be like infection or congenital. Okay, so you put congenital heart disease as a cause of heart failure, if not, repaired, and the cardiomyopathy, and you just put the section of cardiomyopathy, whether it is dilated, constrictive, or what. Okay, so this is just below the cardiomyopathy. Okay, so and put in your mind there is something it would make a strain for the heart, excessive, like thyroid, like obesity, like strain or COPD, for example, or OSA, or some lung, thyroid, anemia. All of them could put load for the heart. Okay, and just these main things. And if it's something like you think that is cardiomyopathy, don't forget that chemotherapy, some kind of chemotherapy could cause cardiomyopathy. So drug history as well is important in heart failure. Okay.
Yeah, some doctor also adds a very important differential cardiac output failure. It's very important as acromegaly or thyrotoxicosis
Yeah.
or Paget disease also.
Yes.
All
Great.
this, yeah, they can cause high cardiac output failure.
Yeah. Great.
Okay, and also very important, presenting in the basis anemic heart failure. It's one of the important heart failure ever. Anemic heart failure. It came a lot. Whatever the cause of anemia, microcytic, macrocytic, megaloblastic, anemia is anemia. Whatever the reason, it might be presented with heart failure.
Dr. Bassem, about the present, when we reach the point when the examiner tell us present your finding, I know in common cases like with findings such as systemic sclerosis or acromegaly, we have the step to mention the finding regarding the signs and symptoms in clinical examination. But in cases of this miscellaneous cases like this peripartum cardiomyopathy, uh, they will minus us if we didn't say a positive finding that we take it throughout our examination. It's difficult to present it, the history on the examination steps
Okay,
when we present to the examiner the first
okay. I will tell you now golden advice. Really, I did it also in the exam. Whenever you have positive symptom in a system, write it under title of examination. Why? Because you're gonna examine this system while examining the patient. For example, in this patient, you have short of breath. So what comes to your mind to do examination firstly? And you will write it under the title of examination in the paper. By the way, you can write in your paper, I will examine one. Here it will be chest.
cardiovascular chest.
No, no, first as short of breath, chest.
Mm.
Agree?
Yes.
Then now you have palpitation, chest pain. This is the second system you have to examine, the chest. Sorry, the cardiovascular. So you will examine the chest and cardiovascular. If you didn't do examination of these two symptoms or these two systems, they will minus you a lot in the physical examination and identify the finding because it's related to these systems. Your case is related to these systems. You have any doubt about this?
No, doctor.
So while presenting, you have to say, I examined this lady. She's lying comfortable in the bed, or she's lying distressed in the bed. She's lying dyspneic. She's using oxygen. This is by inspection. If you have anemia, you can enumerate the signs of anemia. She has pallor, she has jaundice, or if you want to enumerate the vitals, she has tachycardia, hypotension, or whatever, or the pulse itself, pulse volume, pulse character. She has collapsed pulse. All these symptoms as heart failure, you can enumerate it initially before going to the main system affected, which is the heart and the chest. So what about the heart? What you will enumerate as the symptoms or the signs? Now you are talking about positive finding. What you will say in the finding of heart and chest examination, this patient, what you will say? Tell me. From the head down, Dr. Hoda.
Yes, regarding the cardiovascular, would be important to mention on examination of the pulse and
Okay, we
any
mentioned the pulse. We mentioned the pulse. What?
on auscultation, any murmur,
Oh, perfect. Yes.
any
This is for
signs
the
of
heart.
pulmonary, mm,
Okay,
and
what else?
pulmonary hypertension, signs of pericarditis.
No, no, no. Don't go for pericarditis. No pericarditis here. Don't say
Sorry,
something
for
which is
infective endocarditis, purpura, pulmonary hypertension, pulmonary
okay.
congestion, pitting edema. These
You
are
you forget the most important signs in this patient, the signs of heart failure. What are the signs of heart failure, by
mm,
heart examination?
would be the elevated JVP,
Perfect.
polyphasic
This is the one. Yes,
event.
you have to mention raised GVP, pulsatile or not. You have to mention the raised GVP. This it's ABC by the way, Dr. Huda. When you say heart failure signs, ABC, you will say there is raised GVP and there is at the back. This is in any experience in the practical life. You will have raised GVP and three triad. Triad of what? Raised GVP and by basal crackles, right?
Yes, basal crepitation, pitting edema.
Perfect. That's enough. This is as right side heart failure, right? You can add to them. You can add to them congestive or pulsatile liver, tender liver. This is one of the signs, right? This is for the right side heart failure, and for the left side heart failure, the by basal crackles. Agree for that?
Yes.
If you mention these for as a signs of heart failure on the finding, you will get a good mark because
Okay.
this is the possible finding.
Okay. So I mean, when the first step when he told me present the finding, should I just mention what I get in the history, because he in front of him I do the history.
He will
Should I
tell
tell
you.
him?
Yeah,
Mm,
he will tell you either in the history or the
mm,
examination. But initially, you will start by the history because you got history, you talk
mm,
history. So you will start saying by examining by taking history, I found one, two, three. So
mm,
in this patient, two things you will mention. Patient has dyspnea or orthopnea or paroxysmal nocturnal dyspnea. So you can say in jargon because he is the examiner, and there is history of delivery in the last 5 months. If you mention this sentence, you will get most of the mark because this is the most important finding in the history.
yes. So the most important finding that go with my last diagnosis, right? As you
Yes,
mentioned, the most
yes,
important finding in that.
yes. He want to listen to the focused and summarized history in two sentences, not more than this. Don't tell him I didn't find any history of family condition of the. He doesn't want to hear the negative. He wants to hear the positive. Only mention the family history if you have family history. Don't tell him I have no family history. No, either you have family history to mention or don't mention it. This is
Yes,
what they want from you.
yes,
Smoking. If you have smoking in the history and it's related to the case, you have to mention it. Patient is smoker. Patient is alcoholic or drinking alcohol. It might be alcoholic cardiomyopathy. For the driving, you can tell him patient is driving. This is one of the positive things you have to mention, and you have to tell him what did you do for that. If you said, I notice he's driving, I advise him to stop driving, for example. So he will know that you are giving the positive history finding, and you give already the advice related to them. Okay?
Okay.
Okay, how to different, Dr. Abdullah Hisham, how to differentiate between left and right sided heart failure? Yes, so the right heart failure or right side heart failure confined to what? Right and left atrium, right? And with the backflow, it will affect on the venous return. So the venous return will be stagnant at the organs, right? So what's the possible right side heart failure signs and symptoms? Dr. Abdullah, I ask you this question. Let us discover together what the difference
السلام
between right
عليكم
and
دكتور.
left. وعليكم السلام.
شكرا لمجهودك يعني الله يكتر خيرك.
Most welcome.
أنا بسأل كلينيكال يعني جوه اللجنة
Okay.
عشان أبقى سريع شوية. الرايت سايد لو في حاجات عاملة يعني pulmonary hypertension,
No,
pulmonary
no.
embolism ده
No,
الرايت سايد إذا كان
this is the cause. This is the cause of right side heart failure. We are talking about the manifestation. You will not tell him about the cause.
manifestations raised GVB,
Yes, yes,
lower
exactly.
limb swelling,
Yes.
shortness of breath,
No,
tender
tender liver, yes. Yeah, tender liver. And in the left side, you will have?
left side bibasal crackles بس يعني هو ده الفرق.
Yes. Yeah, and you
بس
might have signs of pulmonary hypertension, as you said.
يعني لو لقيت الاثنين يبقى يعني هيبقى
Yes,
باي
there is
سايد failure.
biventricular. Yeah, there is biventricular heart failure. Yeah, there is,
تمام.
yes.
Congestive, yes.
شكرا جزيلا.
Most welcome. Yes, Dr. Dalia? Someone talk?
Yeah, I've said congestive heart failure. Or
Yeah, congestive
biventricular.
heart failure. Yes.
Yes.
just usually في left heart failure or congestive it be congested basal edema. What about right side and other than raised JVB lower limb edema and hepatomegaly? What about the chest?
Yeah, sometimes the patient will be dry. I mean, no crackles.
أيوة leukemia.
Yeah, they call it dry. I think dry heart failure. Yeah, like nothing in the chest, only right side heart failure.
Yes.
And you might have this in the tricuspid regurg. You will have these symptoms with tricuspid regurg. You will have raised GVP with congestive and pulsatile liver, tender liver, and the lower limb edema. With the
عندي
time,
سؤال دكتورة هدى معلش بالنسبة للبريفيوس كيس what about explanation for headache this long standing headache and the other question allergy what is the relation allergy for heart failure ولا هي كانت بتسأل just allergy for shortness of breath like that.
Okay. Regarding the headache, it just to give a differential, was not a specific headache.
Not related, no?
Yes, yeah, not related. And the allergy, because she mentioned she have a dry cough, because usually with acute heart failure with basal crepitation, other than mainly the patient would have a cough with a phlegm, not a dry. So I just think maybe just allergy, or I was confused. So I asked.
Chest, you are thinking for chest.
yeah,
For chest problem.
Yes, yeah, because it was just not in the direction of a pulmonary.
Yeah, cardio. شكرا بارك الله فيك.
asthma, one of the allergic reaction, and it might be presenting symptoms. So asthma might present with short of breath or cough, right? So you can ask this question: is it asthma or sorry, allergy
هي
related?
كان بتسأل يعني to reach it يعني is it cardiac or
Yeah, it's related to other thing. And sometimes you are going to prescribe medication for the patient and you want to know if he has any allergy, and it will be wise to ask about any past allergy. So you can do it in this two ways. Either is it a cause of the presenting symptom, or I am going to prescribe some antibiotics for the patient and I want to be sure he doesn't have any allergy from this medication or from the medication I will mention, which is antibiotic. Even some medication without antibiotics, other than the antibiotics, patient might have the allergy to some medication. For aspirin, for example, some patients have aspirin allergy. So it's okay and wise to ask this question. Do you have any allergy to any medication? It's not a question which is irrelevant, or you can ask it with the previous surgery, like screening for any previous surgery or any over-counter medication, any allergy to any medication. Okay. Any question else? Okay, I will divide the experience according to the session. I mean, what the case I have experience in my exam, I divide them according to the day. So today we have long clinical, so I will mention the two cases, the long clinical cases I had in the exam. The first scenario was about one patient presenting his 50s male, and he has complaint of or notice some lumps in his neck and groin and inguinal area. Groin, axilla, and neck. So from outside, it's like a clear a case of lymphadenopathy. But what the case, you don't know. According to your possible differential, so the most common differential in lymphadenopathy is in this
fever,
age.
HIV.
Lymphoma.
Perfect. Perfect. So HIV, one of the top, and you have to screen all question for HIV. What else, Dr. Hoda, because her exam is near.
Yes, Hodgkin. It could be Epstein-Barr virus or Hodgkin lymphoma.
Perfect. So don't mention type of lymphoma. It's could be lymphoma. I don't know. You don't know or you cannot predict what type of lymphoma from the history, right? So you can say lymphoma itself, either Hodgkin or not. Don't specify the type. This is what I wrote exactly. So lymphoma and HIV and TB. This is what I mentioned before going inside. Okay, when I take the history, it was surrogate and the patient was on the stretcher. The same way I mentioned in the video how I took the history. And when I reach to the HIV, I ask every single question about HIV. Sharing needles, tattooing, piercing, blood transfusion, any casual relationships, and any recreational drugs. All of them were negative, and he has only the lymph node. It comes for a couple of months. This is initially, of course, I analyzed it, but I specify the HIV because not every scenario will ask all question for HIV. This scenario, you must ask about HIV risk habits, and I ask them by name. Everyone, analyze all of them. Okay, what else? It was in the history. He gave me history of clot. I was asking about swelling and like this. He gave me a history of I think either past medical history. I cannot remember, but he has a blood clot in his legs. So this is hypercoagulable state or thrombophilia related. I mention it or I wrote it in the paper because it's one of the important finding you have to examine. What I wrote to examine the lymph node, the liver and spleen, and the legs. And this is exactly what I examined in the patient. I started by the hand, pallor and pulse and vital signs, then the eye, going to the lymph node. All groups of lymph node I examined, even the inguinal. I offered, and they told me whatever. So I expose it the inguinal, and I examined the inguinal lymphadenopathy, the inguinal lymph nodes. The spleen, of course, it was palpable to the mid line, and the hepatic also, there was hepatomegaly. And at the end, before going to the concern, I remember the DVT because it's one of the history. I went to his legs and I offer a tape, and he told me, what you want to say to do. I told him I want to measure for the DVT, and I used the tape really, and I measure here comparison to the other side, and I asked the concern. The concern was, doctor, will my uncle do his work back? He's the one that's supporting us financially, something like that. I told him clearly, no worries about that, but he cannot go back to his work now, and I will provide him sick leave. And the discussion went about the case presentation, of course, the symptoms, and the positive differential. I mentioned as you said, Dr. Huda, lymphoma, of course, on the top. I said lymphoma, but without specifying. But when he asked me what's possible lymphoma here, I said it could be non-Hodgkin because he has multiple groups of lymph nodes. Then he asked me what else. I said it could be chronic lymphocytic leukemia. And he asked what else. I said HIV. Then what else? TB, lymphadenitis. What else? I couldn't. I guess he wants the Epstein-Barr virus. Anyway, I didn't mention it. I remember it outside. Anyway, what I mentioned, he gave me full mark for them. Then he asked me what investigation. I mentioned the same steps I'm mentioning to you in every session. General investigation, specific investigation, bedside investigation, imaging, and invasive tests. He stopped me at invasive. What invasive tests you want to do here? I said excisional lymph node biopsy. He asked me what else, but I guess this question like complementary question
دكتور
because
باسل
again, yes,
CML إذا كان في clotting history type 3 usually there is DVT and clotting thrombosis like this, huh?
yeah. He asked me this question: why this patient has this clot? I said this is hypercoagulable state due to cancer.
Yes,
Yeah,
CML
yeah,
rather than CLL, yes.
yeah. You're right. Any cancer, by the way, it's not only CML. Any cancer can lead to thrombosis, whatever the type of
No, I
cancer.
mean in the evidence of just generalized lymphadenopathy.
Generalized lymphadenopathy was lymphoma. The case was lymphoma.
Yes, lymphoma. CML also can do can cause generalized lymphadenopathy with
Chronic myeloid,
DVT.
no, leukemia. No, this is chronic myeloid leukemia. It's splenomegaly rather than lymphadenopathy.
But there is lymphadenopathy, like CLL also. Both of them can cause generalized
CLL,
lymphadenopathy.
okay, CLL like metastasis to the lymph node and more prone to have lymphadenopathy than the chronic myeloid leukemia.
Yeah. بس
So
الكلوتين ماشي مع CML أكتر.
I said like that, and he accepted the answer. I said it's cancer, and any cancer has probability to have thrombosis. It was also one the question. God remind me. One more question he asked. Yeah, what was the other invasive test you want to do? And I was stuck in this question. I remember later on when I get out.
What is it? Question?
What other invasive test you want to do? What do you think?
Other than bone marrow?
Perfect. Yeah, this is what I realized later on. Bone marrow biopsy. So it's lymph node biopsy or excisional lymphadenopathy, excisional lymph node biopsy, and bone marrow biopsy. This is one of the diagnostic tests, by the way. Yes, you're right.
معناته يا CLL يا CML واحد فيهم. أنا متذكر الفرنسيك شنو ما بعرف التايب 3 تاعت CLL ولا CML.
What is it?
One of them is there is 6 categories. I think CLL, صح? Type
Believe
3
me,
has.
he didn't go to this level of question. I remember now. He asked me because I mentioned this type of test. He told me what specific test you want to do here. So we can ask this question to Dr. Huda. What specific test you want to do for lymphoma patient?
For chronic lymphocytic leukemia,
No.
it's
What?
mainly blood film. Blood film.
Yeah, blood film, one of the tests, and flow cytometry. I mentioned flow,
Epigenetics. Yes.
flow cytometry. No, I didn't say genetic. Really, yeah, I remember something like that, genetic, but I said flow cytometry. And also blood film, yes. These are the question. He asked me about general investigation. I said, yeah, the CBC to rule out anemia. It could be associated with either anemia or leukopenia or lymphoma, lymphocytosis. This is regarding to the lymphoma case. And alhamdulillah, I got 28 out of 28 in this case. The second case was patient, the same, 60s, presented with syncope. And it was nice case because the syncope approach, we practice a lot. We have practiced a lot of syncope causes. So again, it started with the analysis on set course, duration, previous trauma, any attacks before. Yes, he had 3 attacks before. What was before, during, and after? He was one time was sitting, one time was walking, one time in the shopping, and what else? Yeah. Clearly, I asked for the blood sugar. Anyone check his blood sugar? And anyone any previous history of another disease? And particularly, this question give me the case. What's the possible presenting or exaggerating, or let's say the clue for my case? Who knows? I asked all this question. It wasn't related. So he was walking, he was sitting, but there is something give me the case, and it was preceding the attack. Dr. Hoda, what do you think? What's missing in our causes of syncope?
I think the chest pain maybe in this age. We
Perfect. Yes, this is the one. Chest pain or palpitation. So he told me, yes, he had palpitation or awareness of course, not palpitation, awareness of heartbeat. Yes, he said, yes, it was, he felt some awareness of heartbeat. I told him, is it regular like this or irregular like this? He said, no, it's a regular one. Then analysis of the chest pain. He said, yes, any short of breath. Yes, it was sometimes has short of breath. And I analyze also the chest system or respiratory system. Now I realize it's cardiac cause. I want to know what type of cardiac cause, either family history. I ask, but not now. I make it as again constitutional symptoms. By the way, the previous patient, I had constitutional symptoms, and I mentioned it in the history. Patient had loss of appetite, loss of weight, and along with lumps and bumps, and he had also night sweats. Okay, back to the second case. It was negative, no change of the weight or appetite, no constitutional symptoms. Then I followed.
Age بتاعه شنو معلش؟
Sorry?
What is age was age of the
60,
patient?
60, 60s.
Uh-huh.
Okay, I did the system review. Quick headache, any change in any all these systems and questions. Of course, after past medical history, he told me about, I think, diabetes, or maybe the lymphoma patient was diabetic. Yeah, I remember the lymphoma patient was diabetic. But I screened quickly about diabetes in the previous case, but it wasn't the case. Anyway, let's go back here to this patient. He has, I think, hypertension. I cannot remember. Anyway, I finished the history, and while taking history again, I wrote what I have to examine in this patient. What I should examine, Dr. Huda.
Aortic.
Cardiovascular.
Exactly, cardiovascular. Oh, wait, Dr. Rashid. Okay. Okay. Yeah, you're right. So I finished the family history. Yes, he had family history of of heart disease. Uh, no travel history, no. Of course, here no HIV. I didn't ask for HIV at all. The job, of course, and the smoking, alcohol. Yes, yeah. I forget something is very important in this scenario. Yeah, he was hypertensive, and when he told me he has hypertension, I asked about medication list, the compliance. Did he increase the dose? Did he add any medication? And it was a positive finding here. He add some medication the last month. When I asked him, show me the medication list, he gave me 5
No,
medication, and the last medication was
diuretic,
yes, exactly.
diuretic.
Perfect. So now we have two differential. I have to put them in the differential. The first one is cardiac. The second one is postural hypotension due to diuresis or medication because it's recently added. Okay. Enalapril, I guess it was enalapril, ACE inhibitor. Okay. Let's go to the examination. Examination from, of course, peripheral, the hand. I offer postural hypotension. I mean blood pressure sitting and standing. They told me the same in the paper. Go ahead, proceed. I went to eye, nothing. Now the time for heart examination. When I put the stethoscope over the apex, it was very clear murmur, like it will jump from your ears.
Harsh, huh?
Yeah, very harsh, very clear ejection
Oh,
systolic murmur. Initially, I thought it's pansystolic, okay, because you are putting now in the apex. It's right. It's going everywhere in the pericardium. Tricuspid is still the murmur there. I went up pulmonary, still the murmur there. Now the time for aortic, it's very clear now, more accurate and more clear. Then I confirm it with the uh, carotid radiation. Now I got the case and just other system chest examination at the back, leg edema, nothing. And I went to the concern, any concern, what my father is having. I explained to him one of the heart gate being narrowed and the blood is not reaching enough adequately to the brain. That's why he has these attacks of syncope or feeling blackout. I asked, yes, of course, about driving. He said, is it important? I told him yes. While if he has this syncope while sitting, he should be careful about driving and he might be at risk. So please let him stop driving and we will update him about when to restart driving. And time is up. Examiner question was clear about what you heard, what you have, what the positive finding in the history, and what the possible differential. I mentioned the aortic stenosis on the top. He said what else? I said the drug medication. I said what else? I said maybe TIA or stroke. He said there. Yeah, by the way, I did the pronator drift. He said any positive? I told him no neurological deficit. So he asked what else. I said in this age, if he's diabetic, I could say hypoglycemia. Anyway, he checked his blood sugar, so it wasn't low. He said, what else? I said the medication or new medication was added, diuretics. He told me, so what's your plan? I said about admission. He said, why you will admit the patient? I said, patient is have syncope while sitting. So he's a candidate for admission and referral to multidisciplinary team approach. And to stop the new medication, the diuretics. He said, "You will stop." I told him, "No, I will call the cardiology to stop or to hold it, or I will hold it until will be reviewed by the cardiologist." When he asked me this question, I thought he will minus me, but Alhamdulillah, hopefully he give me also the 28 out of 28. Then
what did you say?
I said that I will stop the enalapril, the medication. I stop it because it's one of the
Yes,
yeah,
precipitating.
precipitating, and this is aortic stenosis. It's contraindicated.
Yes.
He asked me clearly,
Yes.
why you want to stop? I told him it's one of the contraindication in the aortic stenosis, supposed not to be given. He said, so you will stop it? I told him, no. I will hold it till will be reviewed by his cardiologist.
Perfect.
Yeah. Then he asked what to do. Do you need to do CT, MRI? I told him in this condition, it's clear like he has cardiac cause. So I gonna do echo, ECG, and chest X-ray rather than doing the MRI. He said, but you suspect TIA? I said, it's one of the possibility because he has comorbidity in the form of hypertension. So still one of the possibility in this age. Then I guess how to manage. Yes. Yeah, I guess the time was up, and Alhamdulillah, this tow station about the long. This is the experience. I think no more question about this. I think yeah. He asked one more question. What this patient need to be operated or any plan for surgery? I said, of course, after multidisciplinary team approach. However, if this patient is having these symptoms of syncope and heart failure in the form of short of breath, he might be indicated for surgery.
Any
And
symptomatic aortic stenosis for
yes, this is symptomatic, and not only one symptom. It's two symptoms: the heart failure and the syncope.
once it is symptomatic, خلاص for surgery.
Exactly, and it's one of the very clear murmur. I mentioned. I said to him, it's clear murmur radiated to the carotid, and once he has symptoms, it's an indication for surgery. Okay. Any question regarding these two cases? Yeah, it's a nice cases, by the way. But sometimes you will have nice cases in the long, but you will have bad cases in the communication. Tomorrow I will tell you about my communication cases. Be ready for them, inshallah. But it's yes, Dr. Dali.
Yeah, just I have a golden tip for the candidates, for the audience, I mean. If you have, for example, a symptoms or something is not common to know the differential, put a scheme. But for example, this is generalized lymphadenopathy, but like could be malignancy, okay, cancer. It could be autoimmune, okay, or something generalized systemic, autoimmune, or but it could be infection, most probably chronic infection, or okay, and put like drugs or reaction to other things. You don't know what that. So put things like that from outside. As for example, this here, it could be leukemia, lymphoma, or it could be advanced malignancy with metastasis. Okay, so I will put malignancy. The broader you put your differential, the easier to get marks and the easier to get being directed by the examiner to the right differential. So if you want to be smart in your presentation or your presentation of your answer, be broader as you could, and then he will direct. And with the feedback of Dr. Basim, he said he put the investigation in broad things and just let the examiner pick something for the some of them to be asking about them. Yeah, it's invasive. What do you mean by invasive? And then we'll go more narrower, and you will know the diagnosis, and you will know that you are in the right way. So please be smart. Don't put yourself on that. Just when, for example, if you want to say you think about mitral valve disease, don't say mitral. So think about valvular diseases. Okay, if you think about lymphoma, say malignancy. Okay, and then what malignancy would you think? I will say lymphoma, leukemia, or metastatic, advanced metastatic carcinoma. Okay, and if it's you think from outside it's infection, please, 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 when you think of chronic infection or something like that, put syphilis, put brucellosis, and put TB for generalized lymphadenopathy. And for the autoimmune, please, 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 or systemic disease, put sarcoidosis, okay? So on connective tissue disease and vasculitis. So when you put broader differential diagnosis, you are in the right way. And by the way, don't, for example, one of the doctors, I'm not sure his name, but he's digging deep on the causes and differential. No, even the examiner, they don't know the details of hematology, okay? They wouldn't be a hematologist, so they know deep answer about everything. So the broader, the safer, and the more easy to get marked and will be directed by examiner and not put yourself in your trap, okay? If you put yourself in a trap, they will go with you. For example, if it's not bronchiectasis and you said bronchiectasis, okay? So if you said obstructive lung disease, not so OBD, and then it will ask you, will direct you to the one of the obstructive lung disease. Be smart in your answer, okay? And for your examination, please try to do, if you, for example, Dr. Basim said, if you have something and you know that is cardiovascular, that's great. And as same, please do some, put in your mind, they are seeking to get from you differential diagnosis. For sometimes, if you got that, this the diagnosis, or the top of your diagnosis, sometimes they put something in the history that to help you to put the second and third differential diagnosis. For example, if for the heart failure, and the heart failure is postpartum heart failure, okay, they might put in the history that the patient is alcoholic. So you need to put your second differential is alcoholic cardiomyopathy, okay? This could be the cause of heart failure, and might put a high blood pressure, okay? So please, if you picked up one differential, try to seek for other differential, particularly for the minor things like alcohol, like some drugs, like some medication, okay? So this is the way they map for you the case. For example, for palpitation, if the patient is, you know that the cause of palpitation is thyroid, but you will find during the history that the patient drinking a lot of caffeine, and so you will put that in your differential. And he's in stress, so you will put stress one of your differential. You got what I mean? So they are seeking for differential diagnosis, not the diagnosis. So be smart on mentioning that. The diagnosis is not, you wouldn't pass unless you do every single skills in the right way, okay? So think about the long clinical consultation is 7 skills. It's not the diagnosis. As long as you put the alarm symptoms and signs, and you drive your history in the the smart way, you'll get the marks even if you didn't reach the diagnosis. Thank you.
Thank you, Dr. Daria. You're right. So
Thanks.
it's not a matter of diagnosis. It's a matter of wide differential, including the case diagnosis. And you have to put differential which makes sense, not every differential. Anything might be related, you can put it and you give explanation for it. And the explanation, not during the discussion only, during even taking the history, you have to ask question to show that I ask this question to rule out this or to rule out that. Okay. Thank you, Dr. Dalia. Thank you, Dr. Rashid. Also, Dr. Dr. Huda and Dr. Salma, Dr. Abdullah Hasham, everyone. Sorry for making this session long, but it was nice cases, or we discussed the nice and common cases in the exam. Postpartum, peripartum cardiomyopathy, and the heart failure as a heart failure topic. And also the cases I mentioned is very important, lymphoma and syncope. Syncope, I guess no diet can go without this topic. In every diet and every center, syncope is very important topic, regardless to the cause. Okay, so you have to know how to approach and are the possible cause and the common cause in cases for syncope. Any question before ending the session? Okay, thank you, Dr. Dalias. Thank you, everyone. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.